Hi class, welcome to Unit 7 where we're going to discuss the nervous system and neurological conditions. The first thing that I'd like to dive right into is a little bit of a review of the function and the divisions of the nervous system. Remember that the central nervous system is composed of the brain and the spinal cord, and then the peripheral nervous system is controlled by 12 pairs of cranial nerves and spinal nerves, and that facilitates communication between the central nervous system and the body parts. Um, and then that's also the autonomic and somatic nervous system, and that is further divided into the sympathetic and parasympathetic. Just a little bit of a reminder of what some of these terms mean. So, autonomic nervous system is involuntary motor control. Somatic nervous system is voluntary motor control. The sympathetic nervous system is the gas. It increases pulse, blood pressure, etc. And then the parasympathetic nervous system is the brake. It slows the pulse, lowers the blood pressure, etc., etc. From there, let's review neuron structure. So these are pictures of the neuron structure overall, and then what happens when it needs to communicate with another neuron. And that is kind of helpful, especially when we talk about mental health medications, stuff that boosts neurotransmitters. That's what facilitates these transmissions. There's only one axon, and that carries impulses away from the cell. There are multiple dendrites. Those carry impulses toward the cell. And then there's the myelin sheath, and that helps with conduction speed. And as we learn about different neurological conditions, parts of these neuron structures can be underfunctioning or impaired. Along with neurological system, we have to do a good history. So when obtaining a history, it's important to learn what family history there is and any current health problems or previous health problems. It's important to know because, for example, if someone has atrial fibrillation and they come in with decreased level of consciousness, we're going to suspect a stroke. We would also want to be sure to assess about alcohol intake and medications anytime a patient comes in with an altered level of consciousness. Be sure to review in your textbook about different cerebral lobes and what behaviors are associated with them. Also review the cranial nerves and what their functions are. When we want to do a sensory test, we use a combination of sharp and dull items to touch the skin. And usually the patient's eyes are closed and we ask them what they feel. Does it feel sharp or dull? We move bilaterally, so we will test the left, then the right, or the right, then the left, because it's important to compare both sides of the brain, whether they're functioning the same or not. With that along, some patients have diminished sensory functions, such as touch. For example, if someone has diabetic neuropathy, they could have impaired due to nerve damage, and we want to make sure that we educate those people when they're walking to pay attention and to watch the placement of their feet and use their sight to compensate for their function loss. I am going to review just a little bit about the brain, specifically the cerebrum. It's the largest part of the brain. It's divided into 4 lobes. It houses the temporal, frontal, parietal, and occipital lobes. You should know what each lobe does. There will be questions about this. For example, the frontal lobe has to do with reasoning, concentration, and judgment, among other things. This is just a great little resource to help you refresh on your memorization of the cranial nerves, which I know you got last term, or actually term 4. This is a mnemonic that can help you to remember those cranial nerves. And then this here is a picture. that shows each of the cranial nerves and how we actually assess it. Um, for example, if we do an ocular assessment, we're looking for pupils that are mismatched, a sluggish pupillary response. These can be signs of an abnormal neurological assessment, but we have to first assess these patients for any glaucoma or any intraocular pressure reducing eye drops because that can alter the pupil responses, and that's a medication side effect and not a true neurological problem. I did type up this slide just to help you kind of bullet point, okay, what does each lobe actually do? What they do is more complicated than what this slide represents, but this is kind of it if you want to have a streamlined reference. So know what each lobe controls. This is a guide that lets you know where sensory perceptions are located. The four sensory perceptions are touch, taste, seeing, and hearing. Be sure when you have a patient that has a sensory deficit, you do things to help them. Make sure the room is free of clutter, the lights are on to help them see better, speak loudly, and it's just a good safety thing. This is a scale called the Glasgow Coma scale, and it helps determine neurological function. So if someone has a suspected or actual brain injury or neurological disorder and they become lethargic, you should always do a full neurological exam first before you call the physician, and you can use this scale. Any change in assessment warrants using this scale and performing a full neurological exam. And this is just an easy scale that we can use as a reference point to detect changes in patients' conditions. When you're assessing it, you can do the eye opening is self-explanatory. You can have them open and close their hands. If they can't cooperate with that, do they react to pain? That sort of thing. And then when it comes to verbal, you can ask questions like what is their name, what's the date, the month, the city they're in, who's the president. When you're assessing remote or long-term memory, you ask things like what year were they born or what city were they born in. When wanting to ask recent memory, we ask about what's happening in the present. So what day is it? What month is it? Who's the president? So just thinking those in terms of remote or recent. Neurological tests that we can do is the Romberg sign. And what we do is we have the patient stand with their feet together, their eyes are open, and their arms are at their side. They should be able to stand without swaying. Now, if they close their eyes, they should also be able to stand without swaying. If he falls or she sways or falls to a side, that's a positive Romberg test. Now, what if your patient sways with the eyes closed, but not when the eyes are open? This is still considered a positive Romberg's. It's usually due to proprioception impairment, and that's an awareness of the body's position. If the patient sways with the eyes both open and closed, then the neurological problem is actually most likely with the cerebral lobe. This slide is the best way I can figure out on how to remember which posturing is with. So decorticate posturing, this is when the limbs come towards the body, towards the core. It's described as flexed internal rotation of arms, wrists, and fingers with a plantar flexion of the legs. It's associated with dysfunction of the corticospinal pathways versus decerebrate posturing is away from the core. Arms and legs are extended. Pronation of the arms, plantar flexion is also present. This is usually associated to dysfunction of the brainstem. So decerebrate flexion decerebrate extensor is worse because that's a sign that the midbrain is dysfunctioning. So with decorticate, the arms are like C's going inwards to the body towards the core, or the spinal cord. With decerebrate, the arms are like E's, and that is worse, and it's a problem with the midbrain. For neurological assessment, sometimes laboratory tests are required. And remember, with these tests, they follow the same rules with any others in every other unit. We have to check for allergies. We have to assess for allergies to contrast. We need to make sure we check renal function before contrast. We want to make sure we hold their metformin if they're going to be receiving contrast, and then we want to encourage patients to increase their fluid intake to help flush that contrast out of their system. From here, a specific type of neurological exam is the EEG. It's a common procedure to look at brain activity, and it's used to detect abnormalities related to electrical activity of the brain, just like an EKG is electrical activity of the heart. EEGs are electrical activity of the brain. This test tracks and records brain wave patterns. We put little electrodes on the scalp, and then a computer processes the signals and records the results. A common intervention is that we will have the patients take deep breaths, and that causes hyperventilation. And hyperventilation causes cerebral vasoconstriction, and it increases the likelihood of seizure activity. And that's something the doctor wants to happen if the patient has epilepsy, to look at what type of seizure activity the patient experiences during a seizure. That can tell us strategic medications that might be more appropriate based on one type of seizure versus another. Another test is cerebral blood flow. We can look at the cerebral circulation and the circle of Willis, which is at the base of the brain. It's important for when someone is having a hemorrhagic stroke or a brain aneurysm. Depending on where the problem is, it will influence how much blood flow is impaired, and also could help determine the prognosis. Similar to like with a MI, the area and the amount of damage will determine what signs and symptoms they have and how severe those signs and symptoms are. From there, we're going to talk about lumbar punctures. They are done with the patient in a flexed position to maximize the space between the vertebrae. The lumbar puncture needle is usually inserted between L4 and L5, and we want that needle to go into the subarachnoid space. We don't do this procedure, but we do assist with this procedure. And during the procedure, the patient would be wearing a gown and be draped for privacy, but this illustration shows you where the L4, L5 is, and then also how that needle travels through that space into the subarachnoid space. This test cannot be done on someone who can't sit still or is very agitated. It causes a greater risk than the potential benefit. So if you have a patient that has an LP ordered and they are restless, they're agitated, we can't do it. We're going to have to notify the physician and either reschedule it or try and perform a different type of test. That said, if we do the lumbar puncture, we will get a little bit of cerebrospinal fluid back. This slide shows you different cerebrospinal fluid samples. A is a normal crystal clear cerebrospinal fluid. B is when there's blood in there, and that could result from a traumatic tap or from a subarachnoid bleed. Um, if it's due to trauma related to the introduction of the needle, the next few tubes of cerebral spinal fluid are usually less bloody. If it's due to a bleed, every vial is going to have blood in it. For C, that is centrifused cerebral spinal fluid, um, and that is with a traumatic tap. And the top part is clear and the bottom part is the blood. So what they did was they spinned it in laboratory equipment. The blood came to the bottom and we could look to see, okay, is the remaining spinal fluid clear or cloudy? And then D is the cerebral spinal fluid from a patient who actually has a subarachnoid hemorrhage. And you can see that there is blood at the bottom of the tube and there's actually a little bit of a yellow tinge, and that's the result of the red blood cells in the cerebral spinal fluid before the lumbar tap. So cerebral spinal fluid can really give us a lot of information about what is going on with our patient. So from here, we're going to move over to talking about some different neurological conditions. The first one I want to talk about are TIAs. They're often called warning signs, and a TIA is a reversible ischemic neurological deficit, transient ischemial attack. It's also known as a silent stroke, and what it is a brief interruption of cerebral blood flow caused by either a vasospasm or systemic arterial hypertension. TIAs last for a few minutes to several, but never longer than 24 hours. When someone, if they present with these symptoms and they're lethargic or unconscious, we're always going to start with an assessment of, do they take any medications? Do they do any drugs or drink alcohol? We want to make sure we do a good baseline assessment no matter what they present with in the emergency room or however they present to your office. From TIA, we move on to stroke. We like to think of those as brain attacks. Like a heart attack requires immediate action, a brain attack requires immediate action. And basically, it is due to a change in blood supply to an area of the brain. Some different things can cause a stroke: hypertension, AV malformations, and one of the highest risk factors for a stroke is atrial fibrillation. And the reason why, which we've talked about this before in the cardiac chapter, is when atrials fibrillate, the blood doesn't get pumped through smoothly, and so blood can pool and quiver in the atrium, and that blood, when it's stagnant, likes to clot. And then when we do finally have a full cardiac contraction, that clot can then get pushed through to the body all the way to the brain, causing a stroke. DVTs, deep vein thrombosis, are another risk factor. So we want to reduce the risk of DVTs in any patient population, especially those at high risk. And being immobile is such a huge risk for developing a DVT, and that DVT can become dislodged and travel to the brain. Hemorrhagic strokes are less common than ischemic. And one of the high predisposing factors for having a hemorrhagic stroke is having an aneurysm. And unfortunately, these are often asymptomatic until it bursts. And so the first thing we need to know anytime a patient is experiencing a stroke is, are we dealing with a clot or a decreased blood flow, or are we dealing with a bleed? This next slide is just a brief overview of what you can see with stroke. So they could have complaints of headaches. They can have mental status changes with like acute confusion, disorientation, memory impairment. They could have aphasia, so an inability to speak or to understand what's being spoken to them. You could have seizures, you can have hemiparesis, you can have visual changes, and we're going to talk about this in lab, but these are all things that we are going to assess for with the NIH stroke scale. And these are things you want to think of as signs and symptoms of stroke in any patient, no matter what nursing unit you work on. The other thing is there's the FAST acronym, and this is patient education. So if you have a patient that is at risk for having a stroke, maybe they're diagnosed with atrial fibrillation, teach them this mnemonic. Okay, face, does their face look even or uneven? Is one arm hanging down, not doing what the other arm is doing? Is their speech slurred or impaired? And then if any of those things are true, time is of the essence and they need to call 911 now. So this is some important patient education for those people that are at risk for stroke and their loved ones. As I mentioned, we could have an occlusive or hemorrhagic stroke, and this is just pictures that show you those different strokes in action. So whether there's a thrombus formation or an embolism or a bleed. And depending on the clinical diagnosis of the stroke, we have different goals. So if it's an ischemic stroke, we're going to do the left side of this frame. If it's a bleed, we're going to do the other side of it. So depending on what's going on with our patient, whether they're a candidate for thrombolytics, whether they have high intracranial pressure or not, is the different routes and ways to management. So this is a little bit more in depth, and you'll get a lot of this education if you work on a nursing unit after graduation that deals with stroke patients. So again, neurological assessment, what are we going to look for? We're looking for any change in cognition, motor, sensory, cranial nerves, cardiovascular assessment, and a great tool is the NIH scale, which we're going to talk about in lab this week. So what are some examples of these? Well, disorientation, confusion, emotional changes, personality changes, aphasia, slurring of words, sensory changes such as paresthesia, visual changes, hearing changes, unilateral numbness or weakness in the face or limbs, seizure, or even a TIA. And as I mentioned, if it is due to ischemic clot or thrombus, thrombolytic therapy may be indicated. There are some rules about whether or not we can do thrombolytic therapy, and we're going to talk about that more on the next slide. But the most common one and what you need to know is TPA. And there's eligibility criteria, so it has to be within 2 to 3 hours of the event. So unfortunately, if a patient is found by family laying on their bathroom floor and we don't know what time they went down and they have a clot in their brain, we can't give them TPA because we don't know how long that clot's been there. There are also some other contraindications that would be reasons not to give TPA because of the risks would outweigh the benefits. So contraindications are listed on this slide, and I would absolutely know these. Thrombolytics, like I said, TPA is the most common. It could be called Activase. That's a brand name. So basically, we give it within 2 to 3 hours of the onset of stroke symptoms. After we give it, we're going to give them an anticoagulant like heparin, Lovenox, warfarin, or aspirin. We're going to give them antiplatelets. We're going to give them corticosteroids to decrease any swelling. We're going to do physical therapy, speech therapy, occupational therapy, bed rest, nutritional assessment, and we're going to assess those carotids. Maybe even perform surgery. So the way to think about these is they are clot busters. So whereas heparin and Lovenox and Coumadin are anticoagulants, they decrease the clotting ability. Clot busters actually break up clots. So they are used strategically when we know where and how long a clot has been placed. TPA is given only in the emergency room or in the ICU setting, but you could get a patient after they've had it, and they are at risk for bleeding for, I believe it's up to 24 hours, even 48 hours after giving this medication. So stroke alerts are pretty much common in most hospitals anymore because time is of the essence. We have to act fast um, with clots or with bleeds. With bleeds, we may have to rush them up to surgery to repair whatever blood vessel has ruptured. Um, so just a refresher here, if it's a right-sided CVA, some common problems you're going to see is impaired proprioception, impulsiveness, and of course, left-sided body weakness. If they have a left CVA, we're more likely to see impaired speech and language processing, and we're going to see right-sided deficits. Drug therapy for strokes, we've already kind of talked about them a little bit, but people that have had strokes will probably be on a blood thinner, such as aspirin, um, warfarin. They could even be on an antiplatelet like Plavix. They could be on multiple medications. We do have to monitor patients on any of these type of meds for an adverse reaction, and that could be something like spontaneous ecchymosis, so spontaneous bleeding. It could be petechiae, so little tiny red dots on their skin. That's a sign of bleeding under the skin. And that could be that there's a platelet problem. It could be that their levels are supratherapeutic. It could be that they're having an adverse reaction. But the first step is assessing for bleeding where they're not supposed to be bleeding. Some non-pharmacological interventions would be making sure these patients have their SCDs and TED hose on. What are we going to do? With drug therapy, we're going to continue to monitor their vital signs. We're going to continue to assess their neurostatus, checking for any changes and or deterioration. We could go ahead and do the Glasgow Coma scale, the NIH stroke scale, and we're going to do this at least every 4 hours, if not more frequently, if changes are noted. We're going to monitor these stroke patients for increased intracranial pressure, and the most common signs and symptoms of increased intracranial pressure is a diminished level of consciousness, headache, restlessness, confusion, nausea and vomiting, speech changes, and seizures. So if we notice any abnormalities, any changes of neurostatus, we are going to notify the healthcare provider. Some other things that we're going to do in addition to the drug therapy is if they have any sort of communication deficits, we're going to develop means to communicate with them. If that's using pictures, if that's using a dry erase board, whatever it takes so that the patient can have a voice. We're going to assess for post-stroke neglect or an unawareness of the existence of one side of their body. An example of that would be if a patient only combs one side of their head or only washes one side of their body, their brain no longer is registering that they have another side of their body that needs care. Patient education that we're going to provide, safe transfer is very important. Assessing for home care needs, ambulatory devices, dietary needs such as using Thicket, close medication scheduling, knowing how to take their medications, what are the side effects that are possible with their medications, and when to seek help. For positioning, when a patient has a stroke or a cranial nerve issue, you want to place them in Fowlers. This helps decrease swelling, and it also goes if you note a neurological assessment change, because usually if there's a neurological assessment change, something is getting worse. And with stroke, they're at an increased risk for swelling. And putting them in this position, then notifying the healthcare provider of the changes is the best intervention that you can do. Some complications that can occur post-stroke: hydrocephalus, uh, vasospasms, or with hemorrhagics, rebleeding or ruptures. What are our nursing interventions? How do we monitor increased intracranial pressure? We've kind of touched on this a little bit. Um, with increased intracranial pressure, remember that the drugs of choice are hypertonic solutions or mannitol. Mannitol is an osmotic diuretic that is indicated for increased intracranial pressure, and you have to use a filter needle when you're drawing this up because it can have little particulates in the solution that needs to be filtered out. And just to hit home a little bit more about increased intracranial pressure, what we typically see with the vital signs is with increased intracranial pressure, your blood pressure goes up, your pulse goes down, your respiratory rate goes down, and your temperature goes up. And versus with shocks, what usually happens is the blood pressure goes down and the temp goes down and the pulse and respiratory rate go up. So it's the opposite. This slide is Cushing's triad. That's kind of the classic sign that there is increased intracranial pressure. So like I said, the blood pressure goes up, but your pulse and respirs go down, and that's the opposite of stroke. And remember that if we think that they have increased intracranial pressure because they're showing these changes in their vital signs, place the patient in Fowlers and then notify the healthcare provider immediately of the changes. That's going to help decrease the swelling. Okay? So that was a lot about strokes and increased intracranial pressure. From there, let's touch base on traumatic brain injuries. These happen with a blow or a jolt to the head. It could actually be caused by something penetrating the head too. That being said, if it's a traumatic brain injury, for example, if your patient has a skull fracture, we have to monitor for bleeding. And you also want to monitor for personality changes with any head injury, along with the warning signs after a head injury that are on the slide here. These are things that we would want to monitor closely for in any patient with a traumatic brain injury or that has experienced a blow or a jolt to the head. So they can have a primary brain injury, and that's open versus closed. So with open, we think of projectiles, knives, guns. With closed, we think of falls, motor vehicle accidents, or fights. This could be something like a concussion, and that involves a blow to the head, and there's a bruising type injury to the brain because it's thrust against the skull. They could have a transient change in level of consciousness associated with bradycardia or slowing of the heart rate, low BP, slow, shallow breathing, amnesia of the injury. They could have headache or temporary loss of mental focus with these concussions. Contusions are more serious. That is due to the greater damage, and they can lead to cerebral edema or hemorrhage. And the prognosis with any primary brain injury is that it's related to the location of the injury, the severity of the damage, and treatment received post-injury. So what I take away from this is anytime you have anybody that experiences a head injury, get them to the emergency room. We've got to get an assessment, and we've got to watch them closely for the next 24 hours for any of these warning signs that are listed on the slide here. Just a little bit of a touch base. Okay, primary versus secondary. This breaks it down very clear for you. Primary brain injury is an actual insult or injury to the brain. The secondary brain injury occurs after it, and that is involving inflammation, and apoptosis is cell death, and also cellular it's programmed cell death is another way to think of that. There's also Coup counter-crew injuries, and that's when there's a Coup is the site of impact injury to the brain, and the counter-coup injury is to the opposite side of the brain. And this is an example of a closed brain injury. There's also acceleration, deceleration injuries, and that's a head movement injury that can happen with a motor vehicle crash. From there, we could have a brain hematoma. And it's just a matter of where that collection of blood is occurring, is how it gets its name. So an epidural hematoma is outside of the dural matter of the brain, while a subdural hematoma is under the dura mater. And then an intracerebral hemorrhage is actually within the brain tissue itself. And this slide has some of the most common signs and symptoms of cerebral hemorrhage based on where the bleed actually is happening. But you can see these are very subtle. And so that's why subtle changes in a patient should never be disregarded. We always want to do a full assessment, okay? Because it could be something as weakness, headache, nausea. And these are things that we don't just, minimize and say, we'll deal with that later. It's not a big deal. It's not severe, because it could be the sign of something bigger. For subdural hematomas, it's a venous bleed into the space beneath the dura and above the acroid, and it's most commonly from the tearing of the veins within the cerebral hemispheres or due to laceration of brain tissue. These occur more slowly, but the symptoms do mirror that of an epidural hematoma. Again, there's complications. Just like with strokes, there's potential complications. These complications due to brain hematomas is hydrocephalus, so excess fluid in the brain, and brain herniation. So if that blood accumulates and starts pushing on the brain doesn't have anywhere to go, and so it could actually herniate down outside of the skull. And it's as bad as it sounds. So if you have a patient in a motor vehicle accident with a traumatic brain injury, what are our priority interventions? Well, we're going to start with assessment, and it's going to be your ABCs. We're going to monitor vital signs for stability. If we see increased blood pressure and slower pulse and respiratory rate, we're going to think Cushing's triad and consider that they are developing increased intracranial pressure. We, even if they're lost consciousness, avoid discussing their condition with them, and know that even if they lose consciousness, they can still hear you and they will be able to remember what you said. We're also going to use the Glasgow Coma scale. We're going to continue to monitor them for other signs of increased intracranial pressures, and if we notice them, we're going to report them immediately to the healthcare provider after putting them in Fowler's. We're going to assess for signs and symptoms of infection, We're going to monitor for signs and symptoms of diabetes insipidus. And if you don't remember what that is, I would make sure you look that up. We're going to monitor their intake and their output. We're going to measure their urine spec grav and serum osmolality. And we're going to place these patients on seizure precautions. Okay, so now let's switch gears to brain tumors. The location, primary brain tumors originate within the central nervous system. Secondary tumors are when another type of cancer from another body part metastasizes to the brain. So it's whether the tumor started in the brain or if it started somewhere else and moved to the brain. Its classification is based on its location and subtype. A really common type is meningiomas. Those are non-cancerous. And then there's glioblastomas, which are cancerous. But keep in mind that whether they're non-cancerous or cancerous, they all can cause neurological problems, especially when they are removed because the body has inflammation and swelling post-surgically. And so we're going to watch these patients closely for swelling, increased intracranial pressure. There are some non-surgical management tools that we can use to get brain tumors out. An interesting one is the stereotactic radiosurgery, and that's when they use a gamma knife, which just sounds like something out of science fiction to me. But it does happen. There's going to be some medications that we use for managing brain swelling, either with surgical or non-surgical management. We're going to use drugs like dexamethasone, which is a corticosteroid, and that's going to help decrease swelling and inflammation. We're going to use medications like phenytoin, which is an anticonvulsant, to decrease the risk of seizures. We're going to use ranitidine, which may surprise you. That's going to reduce gastric irritation, or we could even use a proton pump inhibitor like Protonix, and that decreases the risk of the patient developing a stress ulcer. And with surgical and non-surgical, we're going to closely monitor neurological function for side effects of medications. We're going to have these people on seizure precautions, and pain control is going to be a priority. Let's see. So I would take a look in your textbook about some of the different priority interventions related to different treatment options. And the last topic to discuss is a brain abscess. Abscesses are a collection of pus, and when it's a brain one, it's within the skull. And the bad thing is that it creates a localized increase in pressure, and there's a high mortality for this condition. It can be very difficult to diagnose. The signs and symptoms include things like headache, confusion or inattention, seizures, increased intracranial pressure, a focal neurological deficit. You can have nystagmus, you could have aphasia, or even ataxia. The test that we perform to diagnose this is a CBC, CT, MRI, and a brain biopsy. How are we going to treat it? We're going to treat it with a surgical drain so that the fluid and the pus has some place to go outside of the brain. We're going to use antibiotics. And that's going to kill the bacteria. We're going to use steroids, corticosteroids, to reduce swelling and inflammation. We're going to use anticonvulsants to decrease the risk of seizure activity. And we're going to give these patients mannitol because it is an osmotic diuretic that will decrease intracranial pressure. And then the last thing is just remember how important rehab is. Anytime a patient has a stroke or any other condition, whether it's a tumor that affects cognitive or motor skills, they may need rehab. And rehab's goal is to help the patient obtain the highest level of function possible. Some patients may never regain all function, but they will learn to do the most they can with what they have. It will help them develop a routine and a structured environment to make sure that they do well after being discharged from the hospital. So that brings us to the end of Unit 7. Thanks so much for listening, and I will see you in class.